What you do when you get it, I learned this actually from Dr. Rockwood. This is one of the things that Dr. Rockwood taught me that has always stayed with me. And I will tell you that if you are a busy shoulder surgeon and you do 100 arthroplasties a year, at some point in your career you will get one of these. So you just have to figure out how to manage it. These are my disclosures. None are really relevant to this talk. We'll talk a little bit about background anatomy, which is Dr. Corley, one of my teachers in San Antonio, used to always tell me anatomy hasn't changed in 2,000 years, so learn it. And it's really true. There's a classification that I think about when I think about these injuries, and then management strategies. So vascular injury is extremely uncommon. 0.09% approximate humerus fractures, about 1% of shoulder dislocations. There's been 10 reported cases during shoulder surgery, 5 of which were arthroplasty. So they're uncommon, but they definitely occur. The anatomy, the inflow is the subclavian artery, the outflow is the brachial artery, and the one that we're worried about is the axillary artery and all of its branches. And there, I use the word portion here, it probably should be zone. The first zone is mid-clavicle to the upper medial border of the pectoralis minor. Second portion is deep to pectoralis minor and the conjoined tendon. And the third zone is the lower border of pectoralis minor to the lower border of teres major. And generally, the types of vascular injuries that you see in these three zones are different. There are generous collaterals between the third part of the subclavian artery and the third part of the axillary artery. So many of these, if you get one of these injuries, you will note that if you clamp off the part that's coming from the heart, the proximal portion, you still get reasonably good blood flow from the back end.